I'm sitting here with Gabriel Fernandes. I came across your work. I don't know who posted on Twitter. Maybe it was Gerard McMahon. They posted your study on the lateral gastroc, kind of like stop pointing the finger at the soleus and maybe start thinking lateral gastroc. So I saw it. I read through it. I made a meme, a Saul Goodman meme about the lateral, blaming we should maybe look at the lateral gastroc, stop blaming the soleus. And someone tagged you in the comments of like, this was your study. And I was like, oh, I didn't even know that this was you. So
Yep.
we got on a phone call, had a little chat, and now we're gonna talk about your work. So tell everyone who you are.
Okay. My name is Gabriel Fernandes. I'm a physiotherapist, originally from Brazil. I live in the Gold Coast in Australia now. Um, I've been a physio for around 16 years now. I worked with many sports, Olympic athletes, and everyday runner, triathlete, soccer, and all the sports that you see in Brazil and Australia. Um, I moved to Australia in 2016, just after the Rio Olympic Games. And in 2018, I started my PhD at QUT in Brisbane. Um, at QUT, I was having a chat with my supervisor at the time to try and think on, things to do and, what interests me that he would be able to help me out. And I had, working with sports for a long time. I had this interest in tendons in general, because you see a lot of them. I worked with beach volley, so there's a lot of patella tendon, shoulder, and a lot of runners through my time. And he said that it'll be more suitable to help me with something calf related, because his background was around neurophysiology and mechanisms, specifically associated with calves. So we said, okay, we'll do Achilles tendon. I had read this paper that Soleus paper from Seth O'Neill, talking about how the strength and endurance deficits found in Achilles tendinopathy population was related to the soleus. And then my supervisor mentioned that Ebony Rio had done a study on patella tendinopathy with TMS measuring cortical inhibition. And he said, we have this here, we can do that in Achilles. And we started talking about, the structure of the PhD and how, physiologically speaking, the nervous system controls muscle force through various circuits, cortical and spinal circuits. And then we decided that, we'd look at some of those circuits and try and see, what's happening that is impacting soleus force capacity. So that's what we started, and we built up on studies on that. The first study looked at the brain with cortical, the cortical circuit, specifically the cortical inhibition circuit, and then we looked at the motor neuron via the motor units with like a very high tech EMG system that breaks down the raw EMG into more specific motor unit action potentials, and you can specifically assess and quantify the neurodrive, or the amount of input arriving at the muscle. And we can talk about specifically each one of those studies, but I think the idea was to look at the potential mechanisms that could be impacting the soleus and the deficits that we're seeing in this population.
Mm-hmm. Okay, so yeah, I think probably up to this point, I think even before our phone call, so much of the Achilles, when there's tendinopathy or Achilles issue, we always are pointing the finger at the soleus, and people make the argument of like the amount of body weight loads it has to support, and then it makes up a huge volume of the calf muscle bulk. But yeah, where did you arrive at reading through all this stuff with the soleus? Like, were you finding that maybe the soleus is not so much to blame in these people with Achilles tendinopathy, or what did you see?
Yeah, I think that one thing that I've learned with research is that we can't generalize. We have to be specific to what was measured, and there are obviously a lot of mechanisms and types of contractions that we didn't test. But going to the first study where we looked at the cortical mechanisms, we found that so to measure the cortical mechanisms, we use this machine called TMS, or transcranial magnetic stimulation. So we stimulate the motor cortex area associated to the leg muscles, specifically the calf muscles, and we give a magnetic stimulation. Then we measure the motor evoked potential with the EMG. And what we found is, because it's so hard to pinpoint each of the three muscles separate, because the motor cortex area associated to the legs is deep in the motor cortex, we tested the triceps area as a whole. So we found that in runners with tendinopathy, they had increased inhibition. So if you have more inhibition, you have less input arriving at the muscle. And we found that associated with deficits in plantar flexor endurance. So we used the singular heel raise test, and we found bilateral endurance, deficits in endurance, sorry, even in unilateral presentation. So people with Achilles tendinopathy on one side, we found deficits in endurance on both sides compared to controls. And there was no differences in peak isometric force. We test the isometric forces normally with the knee straight. That's what we used, because you using all the three muscles of the triceps array in its maximal capacity with the knee straight. So that's what we used, and there was no differences in peak isometric force. So it was interesting that we found that there was something happening. There was an increased inhibition. And then we decided to go more specifically. So going from the brain through the spinal cord to the muscle, we have the motor neurons. And the structure that we looked at, it's called motor unit. And it's also called, it's known as the final pathway. So it's the final pathway from the nervous system to the muscle. So it's that connection through the motor neuron to the muscle. So a motor unit is an individual motor neuron and the bundle of muscle fibers that motor neuron innervates. And the way that the central nervous system modulates force is in two ways. You can think as imagine you have a car that you're trying to pull, and you have two people pulling this car, and you just can't move it. So the two people being motor units, the nervous system will have two strategies: either increase the firing rate or the frequency of the action potentials of those motor units, or to recruit more motor units, so you have more people doing the work and producing more force. So looking at the motor unit firing rates gives us an idea of the neural drive, of how much that nervous system is driving that muscle to contract. So that's what we did in the second study. We looked at increments of force and how that modulation was changing with increasing force, because you expect to have a higher firing rate. And again, we looked at the Soleus, the medial gastroc, and the lateral gastroc, and this time with more detail. And we found that the lateral gastroc didn't change the firing rate as the torque increased, but we saw an increasing firing rate in both the medial gastroc and the Soleus, and on both groups. And then was the second study showing that the Soleus, that there was something wrong with the neural drive, but it was more specific to the lateral gastroc. There was another study that wasn't ours from Cruzier, that it was about force sharing strategies. So that's a very interesting paper, and I think it's very, very relevant, because the triceps array is a synergist for plantar flexion, right? So they work in synergy, the three muscles. And what we know, these days on the neuro strategies is that the nervous system has like a partial independent control of each muscle. So it can fine tune and adjust the amount of stimuli to each muscle to adjust for joint stability and control, and to distribution of muscle force. And what this study from Cruzier found was that in people with Achilles tendinopathy, they had 28% lower contribution of the lateral gastroc in force production. And there was a nice study. They used EMG and force plates, and they did a biomechanical modeling of force estimation to each muscle. And they found that the reduction of the lateral gastroc. And that was interesting to see, the support in the findings. And we wanted to try and understand if there was something that we were missing, right? Because this paper of Safon, you said found that the soleus were the muscle with deficits. So we looked at another type of circuits in the specifically to the soleus. One of them is called persistent inward currents, and it's a type of motor neuron excitability. So the PICs is a mechanism of amplification of synaptic input. So it amplifies the amount of input arriving at the muscle. And one of the interesting things with PICs is that they are very sensitive to inhibition. So if you have that cortical inhibition that we talked about that we found in our first study, arriving at the soleus, you would see a reduced PIC because the inhibition reduces that PIC activity. So we looked at the PICs and we looked at other types of modulatory drive, the neuromodulation, such as acceleration and the firing rates of the motor units as well. And we found that, and we looked at the soleus of the people with Achilles tendinopathy and without. And again, there was no differences in any of the measurements that we did in the soleus. So as far as what we studied around soleus physiology and the nervous system playing a role in soleus force production, not only our study, but our other studies as well that looked at that, it doesn't seem to be, we can't find anything that justifies the soleus being with an altered capacity to produce force. As I said, like there could be other types of contractions that we didn't measure, like explosive contractions, or maybe even during running, or other things that we didn't actually test. But with the things that we tested, there appears to be no difference between the people with and without Achilles tendon pain in soleus physiology, neurophysiology, should say.
Hmm. For me, maybe people listening to, so that study the Seth O'Neill study on the soleus, like kind of, looking at what the soleus limitations with Achilles tendon. What did he test? What did he find in that study that made people start thinking soleus is something we need to look at?
Yeah, so they tested the isometric peak torque with the knee straight and knee bend. And the assumption was that because the gastrocs, they work less with the knee bend, they found differences in torque on both positions, right, between groups. So their assumption was that if the deficits in force were in the gastrocs, you wouldn't see it as you bend the knee because it would be less active. The gastroc being the deficits being in the soleus means that you can see on both knee straight and knee bend. That was their assumption. But I think that the issue with that, and I should rephrase it, I think that there's a possibly limited view on that because it's not just about mechanics. You know, like when you bend your knee, you have less tendon strain because the tendon of the gastroc gets less stretched. You have reduced neurodrive to the gastrocnemy, and it might be that you have some compensation of the other muscles. It could be that the compensation is not great, and maybe that's why you see the deficits on both knee positions. So it could be that, the soleus in that specific subgroup that he tested had a greater deficits. And again, it was the foundation of my PhD was these studies trying to identify the deficits in soleus. And the idea is not to say that he did something wrong, was to say that there might be something else that we need to be looking at instead of just focusing on the soleus as the main driver of Achilles tendinopathy, as we have been for a long time.
Okay, so you're looking at these three individual muscles and the drive. So I guess maybe before I ask this question, that analogy you had of like pulling the car, and you could add more people, or you could make them, I guess, pull harder, like increase firing rate, right? Those deficits you didn't find. You only saw those deficits in lateral gastroc. You didn't see those deficits in medial and soleus.
No.
And these are people with Achilles tendinopathy.
There was two groups, one with Achilles tendinopathy and one without. They're both running groups, both runners. And there was another interesting study that tested firing rates as well, but with higher intensity contractions. And they didn't find anything in the medial gastroc and soleus. And they didn't find a lower reduction or a low activity of the lateral gastroc. They found that at higher contraction intensities, the lateral gastroc was working harder. So again, I'm not saying the lateral gastroc is working less. We're saying that there's something wrong with it. So it might be that this modulation is altered and it's impacting it, the control of the muscles. There's this with synergist muscles and with our understanding of the common drive and this, I don't like the word motor control too much because I think it gets taken out of context a lot. And we're not trying to, get very niched exercises to fix something. It's not the idea behind it, but in terms of how the nervous system controls movement and our understanding in neurophysiology improving, we can see that this people with specific coordination strategies, as I said, with those specific deficits in lateral gastroc, for example, there was a study that found that for the triceps array and for the quadriceps, people with specific signatures, which is what they called, in a movement, tended to reproduce the same recruitment pattern in other activities. So I think what we're trying to say is that this altered neurodrive that we're seeing in isometric contractions may be seeing other types of exercise, like running, for example. One of the interesting things that I observed, I was questioned a little bit about how the lateral gastric deficit would come about, right? As a primary issue with tendinopathy, and we exactly don't know that, and that's not what we try to answer with our studies. But one of the hypotheses is that the soleus is a muscle with a huge endurance capacity, right? It's a fatigue-resistant muscle. Running is an endurance exercise. With these independent coordination strategies, the muscle that will fatigue quicker will not be the one that is like a high resistant to fatigue muscle, like the soleus will be either lateral gastric, medial gastric. But this fatigue-inducing exercise like running probably wouldn't be enough for you to stop running because you're going to feel, my lateral gastric is tired. It's your whole triceps array producing force. So when one muscle gets less active, as I said, the nervous system has its capacity to readjust the input, and we don't know to what extent, but to maintain the same force. Because as I said, like we didn't find deficits in peak force, but there were deficits in your drive. So it could be that there's compensation, like one muscle increasing to compensate deficits of another muscle. And this is where we are starting to find interesting things, researching tendinopathy. Then we want to keep exploring to try and understand what happens, when does it happen, and how we can change that. I think that's the main thing, and whether we can change it or not.
Yeah. Okay. Yeah, you said a lot of things there. The fatigue thing. I think when we had our phone call, you were talking about that, how when we talk about rehabbing an Achilles tendon, it's like we need heavy loads, and everyone says we need to do that. But how do you even like with your work, how do we say that, yeah, you have this deficit, this motor drive problem with the lateral gastroc, but it's like, yeah, what's going on when you're running? Do you have any speculations of like what do you think happens with the other, because your contraction types were isometrics, right? That's what you tested,
Yep.
was isometrics. Yeah. And then I guess it probably has some carryover, but it's like, how do you start to test what's happening when someone's running at like mile 1 or mile 10 or mile 20? What do you, I don't know, can you speculate what you think is happening?
It's, as I said, it's very hard to expand our findings to other types of contractions. One of the limitations with the high density EMG, which is the system that we use to look at the motor units, is that to look at, so the way that the system and the algorithm finds and decompose that into motor unit firing rates is that it gets a raw EMG, and this high density EMG electro matrix has up to 96 electrodes. We used 64 in our study. So imagine you have 64 monopolar EMG electrodes, and then you can get them bipolar connecting to one another because it's one big matrix with all those electrodes. So you have a lot of EMG data, and these decomposition methods that exist, they identify the action potentials, and they say, okay, so this is one motor neuron, this is another motor neuron. Then you separate that into individual motor units or motor neurons, and then you're looking at identifying the motor units for you to do the analysis. But the way that the high-density EMG works is, if you do dynamic contraction, you're changing your muscle length and the deep layers of the muscles as well. So that the sample of motor units you're getting, they're going to change in location. So you're going to get a lot of noise and probably not good quality data to work with. So we're still limited to isometric at the moment. One of the interesting things with running, and obviously, as I said, we can't get our results and say that that's applied to running, but running, it works the muscles in a quasi-isometric contraction. So the muscles are in a submaximal intensity contraction, and they're not in a real isotonic contraction model. So it's a more isometric, and the tendons are springing and stretching more than anything. So it's not that far from what we're doing, but obviously we don't take in consideration with those specific studies that we did the tendon behavior that would be very different with running than what we do with the isometric stuff on dynamometry.
Okay, the EMG, it maybe I've most of the I mean, it's in like the hypertrophy world, and I'm a little bit in that, and there's been some like criticism of like anyways, the surface EMG. I just immediately think from like the most surface level understanding is like the gastrocs are superficial and the soleus is deep. So is there any issues when you're trying to see the EMG with the soleus because it is so deep, or yeah, what's going on there?
Yeah, that's a very good point. No, there isn't. For two reasons. One, the location that we put it, the electrodes, just below the muscle bulk of the gastrocs, and where the Achilles tendon sits at that level is just soleus. So you can clearly get the data from the soleus there. There are many studies that have done that way. These high-density EMG data and tests have been extensively validated, and they are as reliable as intramuscular EMG. So we do not compare that with surface EMG, with the RMS analysis and surface EMG amplitudes that we normally see in other type of studies. These are not the same types of data. So it is electromyography, but the data that we get out of the electromyography is the related to the motor unit, not the actual EMG activation amplitude that we normally see in those strength and conditioning exercise science research. So this is more specific to neurophysiology, and that's even being used in stroke, motor neuron disease, to look at aging. So it's a very strong and accurate representation of neurodrive.
Hmm. Okay, you said earlier this Ebony Rio, the Ebony Rio stuff, maybe that was what started the whole cortical inhibition thing and tendinopathy with the patellar tendon. And you're going and looking at the three different calf muscles. Did she look at the quads individually? Was she able to do that, or was it just the quads are inhibited, period?
Yeah, if I'm not mistaken, I think she looked at the rectus femoris instead of the quads as a whole. Um, it is the same deal with the triceps array. Like so the motor cortex area is tiny. The coil is the size of your head, and it's like a figure eight coil. So the center of the figure eight is where you need to be positioned to stimulate. So you have some in some setups you have a neural navigation system. So you're visualizing what is stimulating, and some use other muscles as a criteria to adjust your position. So the way we did was we had Soleus, medial gastroc, and lateral gastroc with a normal EMG just to get the amplitude response. And we had another EMG on the tibialis anterior just to see if we're getting high tibialis anterior activity, means that we're going dorsiflexion or plantarflexion. So it was one of the things that we used to make sure we're in the correct position. I can't remember the top of my head what Ebony used as to control the position. I don't know if they had the neuronavigation, but I think that they just focused on the EMG on the rectus femoris, if I'm not mistaken.
Are there other studies on other tendons of the body and this cortical inhibition, or is it really just like patellar and Achilles?
I think it's just patella and Achilles. Upper limb, it's not that hard to do, but the tendons are hard to to identify. Like it can stimulate the biceps or the deltoid really easily, but you wouldn't be able to get the data and to be selective with the rotator cuff. There's not much stuff done in hip, as far as I know. With TMS. So I think it's just the Achilles and the quads and the patella.
Okay, this lateral. So when we were talking last week, I was speculating myself on like, okay, why does this lateral gastroc seeing this inhibition? And I mean, you've probably done the same for yourself. But this subtendon twist. So I was kind of talking about, is it because this lateral gastroc twists and that's like the deepest insertion on the calcaneus? But yeah, is there any credit to that, or is the twist just like too variable between people?
I think it's hard to say. It is variable. I think they're classified into 3 different types, 2 being most common and 1 being more rare. We normally have the soleus as the deeper layer and the gastrocs as the most superficial layer of the free tendon. But I'm not sure if it might be that we get at a point that we're identifying the phenotypes of subtendon twist and those that will be more likely to have tendinopathy or not. But I don't know if we're quite there yet. I think there's still a lot to understand of what it actually means. If it's just an anatomical variation of that's going to be predisposing people, we still don't know.
And that study you did was Achilles tendinopathy mid portion. It was people with mid portion Achilles.
The first one was yes. Or the first one was the two first ones. The two that we talked about were with mid portion, and then the latter one that we haven't talked about yet, which is the foot position, we included in session as well.
Okay. This I've had a number of people on with like Achilles calf, and there's this whole thing like Soleus is I don't know the percentages, but like 50-50s. I mean, and that's this probably variable too, but 50% slow twitch and then 50 fast, and then the gastroc is more fast twitch than slow twitch. Is that anything that has any value to look at in all these things we're just talking about? In terms of the neurophysiology, is there any difference with like more of a slow twitch muscle versus more of a fast twitch muscle?
Well, there is for running. Like if we're talking about, as we talked about last week, running is an endurance sport, and if you have a muscle like the soleus head that has a higher percentage of slow twitch fibers, higher resistant, fatigue resistant muscle, I see it as a very, very hard to see that muscle will be the most affected because it's the strongest in the plantar flexors, is a high resistant to fatigue, and running is endurance sport. Whereas the lateral gastrocnemius and medial gastroc have less of that, slow fiber twitch and will be more likely to fatigue before than the soleus. One of the things that we talked about last week as well that I find it interesting is that, I'm running this survey, and I think it's a good opportunity for me to share my survey. I'm running this survey on clinicians' understanding on Achilles tendinopathy, and there's few questions about whether how you understand your pathophysiology or your diagnostics and your treatment, and how each type of treatment differs, and all that. And it is something that's been growing in research these days, which is a co-design. So you interview, your consumer, and get your consumer feedback. So I did that. I interviewed some people, and experts that treated and saw runners with tendinopathy or athletes with tendinopathy. And during this interview, one of the people that I was talking to, as I asked, do you normally see, a lower endurance capacity in the calf of those people? Because everyone talks about, heavy, slow resistance training or plyometrics, and so it's all tendon based. And obviously, I understand that, it's a tendinopathy problem. So the load needs to be focused on the tendon when we want tendon adaptation. Um, but as we talked about the neurodrive and all that and the distribution of strain, if the muscle is not contracting, like if you're passive, if you're just sitting, watching telly, there's no strain going on the tendon because you need that muscle contraction, right? To get that force distributed and across. So while they're running, you have that contraction, maximum intensity for, prolonged period of time. And deficit in endurance is something that we've been seeing a lot in this population. So I asked this person, do you normally see that? Because he's a very experienced clinician, and they said, yeah, they did see that, but and I asked how they address that in the clinic, and they said, well, I don't, because they get that from running. So what I don't understand is, if they're getting that from running, the endurance component, shouldn't they not have endurance deficits if they're getting that from running? So I feel that, a lot of the interventions that are done for Achilles tendinopathy are tendon based, like you want to improve function or structure. And then on the other hand, we say, we don't care about structure, like treat the donut, not the whole. So I think that, different treatments focus on different things, but we might be failing to address those little things that we're talking about, like the specific deficits of the lateral gastroc or the endurance deficits that we are seeing in this population. I was watching your podcast with the CrossFit guy, forgot his name,
Yeah, Brent Fikowski.
Brent, and he
Yeah.
was saying he was a high level athlete and he never did a calf raise. It's exactly what I'm talking about. Like you're a runner, and you don't train your calf raises. And as we know, and as your strength and conditioning, running doesn't work the muscle the same way as a calf raise. Even your body weight single leg calf raise will work, to fatigue, will work in a different way than running. You can run for 2 hours. You can't do more than 40 calf raises when a single leg. You're gonna get fatigued. So the muscle work in a different manner, and the environment you know that you're working on might benefit your muscle in a different way. The same way as you do heavy loading and you're getting your stronger, bulkier muscle, and that will get you, more force produced, and that will help with endurance as well because your muscle getting stronger, but it's not specifically endurance. So I think there's like a few things that the research is really hard to translate into clinical practice, but one of the things that we are seeing is deficit in endurance, and I don't know how much that's being addressed in clinic. I don't see specific endurance exercises in a lot of the guidelines. I don't see that being specifically said. They just say, any type of contraction, any type of exercise. But do clinicians consider endurance, or are we always considering tendon structure, which, endurance wouldn't do anything for it, because it's low load.
Yeah. What do you think needs to, on the training side? What do you think? Are you at that
Well,
point of having a suggestion for, like, how do we build that endurance?
I think that one of the easy ways is, it's with anything in physio, for example, like if you are testing a patient for a balance issue and you're doing a single leg balance and you see that they can't hold for 10 seconds, you can start with that, right? So, one way that I think it's easy to do, and it's being used more and more, as a single leg calf raise. Um, I like to do it off the floor instead of a board or inclined board or a step or something, because it's easier for patients to do if they don't have a board, or some people might use a 10-degree board or a 45-degree board. So which one would the patient get? So it's hard to compare progression or to compare with your other patients. So I would normally do it off the floor, especially because that can be used over with insertional tendinopathy as well, because you're avoiding that compression, the entheses. And just do as many as you can. I think that the overall consensus is that we have a metronome to control pace, so patients are hurrying up to do it quickly. And I think understanding the criteria, right? Like I think that exercise or sports science does that very well with protocols and guidelines and understanding fatigue specifically. I remember when my first fatigue test that I was doing pilots, and people just say you got to scream that in their ears, and you stop the test, not them. And so it's because they will give up, like it starts burning, they just stop, and they haven't reached fatigue yet. They just didn't want to continue. So sometimes you just got to push them through. Obviously, if it's not provoking a tendon, it's not causing an increasing pain. If it's just that burn in the muscle, just push it through, do as many as you can. And it might be a first step. And then, you progress with loads on that after you reach a certain amount. I wouldn't compare with the other side, because this being something that is being observed not only in Achilles, but in patellar tendinopathy as well, that sometimes the deficits are bilateral, even in unilateral presentations. So I think that's called for a normative data for athletes. We have that, and it's a pretty good study done from Kim Lozier for general population with the calf raises, but we don't have that for athletes. And I think that might need to happen as well at some point, so we can perhaps use that as a normative data and try and stratify where your patients are and see if there's a way of understanding risk and like a cutoff point for minimum number of calf raises for those at risk of developing tendinopathy. But it's just light years away, I guess.
Yeah,
We'll get there.
that's kind of what I did for the endurance. Is like we have that single leg endurance test, and I'm like, let's just do that. Let's just do that a few times a week, and we're going to be training endurance. I was going to say earlier on the bilateral deficits. Yeah, when you have like a patellar Achilles, is like you could see, or I guess let's just talk patellar. You're going to see like that side much weaker, but it's like then you have a healthy side that's stronger for you. But if you probably look at normative data, you're like they're both weaker. With this cortical inhibition, when you have people with unilateral tendinopathy, is it the same side to side? Do they have that cortical inhibition of the lateral gastroc on both legs, even if they just have pain on one side?
That's a good question. We didn't measure that. It's very time consuming, the protocol, and we prioritized the symptomatic side. We looked at people with bilateral tendinopathy, and we focused on the most painful side. But then we did a sub-analysis of the single leg calf raises just with those with unilateral presentations, with excluded of that analysis the bilateral presentations, and the deficits in endurance were on both sides. I don't know about the cortical inhibition. That's a very good question.
Yeah. Okay. I think earlier you were talking about I guess was it peak force? What was the thing you were talking about? It was like you don't see that change in peak force, right? With some of these Achilles tendons. Probably variable. This lack of endurance, is that pretty much across the board of people with Achilles tendinopathy? You're going to see these deficits in endurance?
Look, the deficits in peak force are a lot more conflicting. And there was a recent systematic review that even questioned whether those deficits exist or not, because of how conflicting they were. The deficits in endurance are a lot more perceived. That Seth O'Neill paper did endurance as total work done. So they did a dynamometry. There's some studies from Silbernagel. They used the single leg raise. I used on my studies the single leg raise as well. And there's some other studies they use there as well. So it's being more consistently observed. In terms of the deficits in peak force, I can't say that there is a deficit in maximal capacity, but I think one of the issues as well is that a lot of the studies measured the peak isometric torque with the knee bend. So as we talked about, like if you're just measuring the knee bend, you're not working the full capacity, because again, you're biasing soleus, you're looking at the soleus capacity to produce force, and that might be one of the reasons why, the research is not more certain to what's happening in terms of maximal capacity, maximal force production as a metric. It could be that once we only look at papers with the knee straight, that we see something different than what is out there these days. But at the moment, I think there's so many different protocols and ways of measuring that we still sort of like looking at, apples and oranges a little bit.
I kind of look at the seated or the bent knee or straight knee, and I'm like the bent. I mean, one of the problems is always controlling for variables of joint angles and what's helping. And I'm like, if you do the bent leg, it seems like there's no way to get around. You have to load the soleus and that subtendon. But when you get to the straight leg, it just seems like you could be using your knee, you could be using your hip. Is that one of the issues in the research of like, if you sure you're going to do a straight leg calf raise, but how do we know we're really isolating the calves?
That's also a very good question, Jake. I think that when you're doing dynamometry testing with the knee straight, we have a strap just above the patella, so it's making the knee straight, and we bring the participants as close as we can to on the force plate, on the dynamometry plate. So the only change that we see is from the ankle, because your knee is in full extension, your back's, you're holding here, you're not pushing or pulling anything, you're just producing force in your ankle. So it's a lot hard to cheat. Whereas with the knee bend, it's a lot easier to just do like a leg press, movement when you're testing. So I think the way I've tested, I think it's a lot more variable with the knee bend, to use to compensate and use other muscles than with the knee straight, because the knee straight are pretty much locked in and you can't really move besides your ankle. When you're doing a leg press in the gym, obviously you're not going to have your knee locked and not doing anything, but you can pretty much maintain it's like a stationary knee extension and you're just moving your ankle on the leg press. You can do a standing calf raise on the machine on the Smith or on the that's standing calf raise machine, and even if you're swinging your hips, you're not really moving much. So it's mainly your ankle movement there. And remember, I talked to you about that on the chat last week. I'm just gonna get the name here of the paper. I've mentioned that to you last week. So it was a paper from Kinoshita in 2023. They compared muscle volume of the medial gastroc, lateral gastroc, soleus, and they compared the triceps area as a whole, as like a whole hypertrophy over a period of time. I can't remember if they did 8 or 12 weeks, and they compared seated calf raise with a standing calf raise. What they saw was that, as we expected, the hypertrophy of the lateral and the medial gastroc was greater with the knee straight compared to knee bend. But there was no difference in soleus hypertrophy. It was the same. And the overall triceps area hypertrophy was greater with the knee straight. So in terms of muscle adaptation, the knee straight would work all three muscles more efficiently, and you're going to have more load, and you're going to, have higher loads to do your exercises. You have higher strain on your tendon when you bend your knee, even though you go to more dorsiflexion, because your two gastrocs are not working in its maximal capacity, the strain through the tendon is reduced. So I can see that in terms of tendon strain being sometimes used as a starting point. But you can also do a, standing calf raise with no weight if that's your starting point, because you don't want to load the tendon heavy, right? Mm-hmm. So I don't see myself a specific reason for tendinopathy to do a seated calf raise. I would see it for a soleus strain, muscle strain. You're trying to, really make sure that you're taking the gastrocs out of the equation so you don't overload and be provocative with higher load in this sense. But in terms of tendon adaptation, tendon strain, and even in working the whole muscle, I really don't see a point of the seated calf raise, really.
Yeah. Yeah, I kind of, for me, I'm always like, if it comes to training calves, I'm like, we have to start with something straight leg, and then if they want to add more, if they have time, we could do a seated one. But yeah, I was gonna say the hyper that study with the hypertrophy. When you have these people with Achilles tendinopathy, I mean, I'm aware of it with patellar, and I don't need a study on patellar to tell me, but I've seen enough people with patellar tendinopathy, and their quad is tiny. You can just see it with the naked eye, where it's like, okay, that you're clearly inhibited there, and we should bring that quad muscle up. I mean, you can even see it side to side. It's like way smaller that side. We need to bring it up. With the calf, I've always struggled with this. Do you see this atrophy in the calves with this long-term Achilles tendinopathy?
Um, it's there was one study. I don't know if there's more that have seen that. There was one study that saw like a selective atrophy of the lateral gastroc. There was a Cruzier study from Marion Cruzier. I can't remember the year. But she used the muscle volume as part of the calculation to estimate the force production, and there was a reduced volume of the lateral gastroc in the tendinopathy population. In terms of whole triceps array, we measured runners, and a lot of the runners don't have like big developed calves. Like there's not very common unless you are you're doing a resistance training, unless you're like a triathlete and you're doing some other types of exercise. But if you're just running, and a lot of runners don't do resistance training, I think things are changing these days. But there was a lot of concern of getting bulkier and slower. I don't know how much you see of that, of people being resisted with doing weight training. But that's definitely something that we are going to be measuring. I'm co-supervising a PhD student looking at Achilles tendinopathy, and would potentially be looking at ultrasound and muscle volume and fascicle length and adaptations as well in this population, because that's definitely something interesting happening there.
Hmm. Okay, this makes me think of, if you're not, I mean, based off your work, this we kind of are like blaming the soleus, I guess. Yeah, people blaming the soleus for these Achilles tendinopathy. But I'm like, okay, if they're not having those deficits in the motor drive to the soleus, um, maybe then the hypertrophy stays the same. And then maybe if that hypertrophy is, or that atrophy is happening just in the lateral gastroc, a question for you on that. Maybe that's why I've had a hard time of like, I don't see a clear muscle atrophy in Achilles tendinopathy, but I see a clear muscle atrophy in the quads because I can just see them. Um, what is the percentage? What is the bulk of the soleus? Do you know off the top of your head the bulk of the typical soleus in terms of the muscle
No.
mass of the triceps? But it's quite a bit, isn't it? Quite a bit more than the gastrocs.
Yeah. So this is huge.
Yeah, yeah. So maybe, just thinking now, I'm like, maybe that's why I don't see this atrophy, because if the soleus is not inhibited and not getting weaker or not whatever, going through this bad cycle, maybe the calves stay pretty big. And like, if that lateral gastroc shrinks, maybe that's hard to see with the naked eye. Um,
Yeah.
yeah. Okay. We spent all this time talking on this, and we haven't talked the rehab or the training for the lateral gastroc. The little bit I know is like looking into the bodybuilding world of like, they'll do feed outs for like medial This was like way back in the day. They're like feed out for medial gastroc, feed in for lateral gastroc. Yeah. In terms of the rehab and the training, if we can kind of accept that there might be something bad going on with the lateral gastroc, what are we going to do in training and rehab to restore this?
Yeah, I think it's precisely that point they brought up. Like the last study of my PhD was looking at the effective foot position in the medial and lateral gastroc activation. And that was based on two studies. One was in looking at similar things with motor units and EMG activity in healthy population, and that with the foot position we were able to selectively induce those changes in neurodrive, that exactly as you talked about, the foot position in increase the lateral gastroc, the foot position out increase the medial gastroc. And there was a study with like a training study done in Brazil, in São Paulo. I think it was São Paulo, might have been São Paulo, but it was in Brazil. And what they did was a training study for 8 weeks, and they measured the hypertrophy of the three muscles over this period of time, and compared. They did a leg press, ankle plantar flexion on leg press, resisted and increased the weight accordingly, as people got stronger over those 8 weeks. And they found that the foot position in induced a lateral gastric hypertrophy, and the foot position out induced a medial gastric hypertrophy. So it's not only the acute changes that we saw in our study and that those other study that I've mentioned saw, but there's a chronic effect as well. So it's not only about changing the neurodrive and changing the EMG, as a lot of people would say, but EMG doesn't mean anything in terms of muscle contraction. But there is a training study showing that actually changes the demand of the muscle, and the muscle gets, works harder and adapts. So the way that I see it is, we can't say do this for tendinopathy because you'll get better, because we don't know. I think the next steps would be doing some sort of clinical trial and do the foot position in and see how that affects the visa A's and the tendons A's and all those reported outcome measures that we have for tendinopathy, pain during running and all that. But on the other hand, I don't see the harm on doing that. So one thing that might be good at addressing these deficits in the lateral gastric could be adding a plantar flexion exercise with the foot in on top of your exercise routine. And it might be that you see something, and it might be that at some point when we do this study, this RCT, that we actually can prove that it works. But in the meantime, I don't see the harm of doing it. And the same way as we use, as you said, if you have time, do your seated calf raise. Some people would start with doing hops and lunges, hops and jumps, and different types of plyometrics to work the tendon in a different way. You might be there 1 day a week or 2 days a week, you're adding a couple of exercises with the foot in. And it might be, the missing link. We don't know, but it's just definitely on the list on things to do, and try and see how that randomized control trial works on that changes in function and pain in these people with tendinopathy.
If I've done this on the seated calf, I'm wondering what you think. Because the gastroc is not working well in the seated calf, there'd pretty much be no point in doing different foot positions on well, I mean, maybe there's a difference for the soleus, but at least for the gastroc, how much worse is the gastroc working in a seated calf? Like, yeah.
It can get as low as 50%
Okay.
less. Yeah.
Yeah. So the
depends
the
on
foot
the knee
in,
angle, but about 50% less.
so the foot in training is like with a straight leg.
Straight leg.
Yeah.
It'll be like we use the foot in position, but it's sort of like you're rotating your hips inward, like not your foot. Your foot is positioned inward, but it's like it's a straight knee. You're rotating your whole leg inward, and I feel that it's easier to do on either standing or calf raise than the leg press. I think the leg press, because of that compression of the leg press, some people might feel uncomfortable on the hips doing it. But whatever works, as long as the foot's positioned inward as much as you can. It doesn't have to be 45 degree or 90 degree or whatever degree. It's just, some people would have structural anatomical limitations, but as much as you can rotate it inward, and see how that changes for you. It might, it's with the whole isometric thing, initially some people work, for some people it doesn't work. So for those that work, it might be a good strategy to do. Some people have clear, small lateral gastrocs, so they, and it might be that there's just their anatomy, and there's nothing wrong with it, but I don't know. I think we haven't figured out yet who would benefit from it and whether this would add any extra benefit than just a regular uh, exercise training. But I guess that whatever position is comfortable and as part of your training, not as a replacement of the 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 rehab protocol that you already have in place.
What are you doing with when you're doing that foot in? As far as like the distribution of pressure, is it like staying on the first and fifth met heads, or are you like going on to the pinky toe, the outer met head? What are you kind of cueing people?
Trying to go towards the big toe, because if you go out, you sort of like using your inverters, with ankle stability and all that. So trying to make sure that you're pushing off and your toes are on the ground, they're not rolling out. Yeah, so just maintaining your whole toes on the ground as you push
Hmm.
to give you that foot stability, not letting your ankle roll out.
Okay, have you looked at this in terms of like the biomechanic gait cycle? How like the soleus is engaging kind of early on, and then this more like later finishing is the more gastroc. I might have that kind of whatever. I'm just trying to simplify it. Um, yeah, have you looked at that at all? And you're like, maybe these runners, they're really good at this early stance phase of the soleus is really good, but it's like maybe that finishing all those strides with the gastrocs is like maybe they're not as good at that because you're having this lateral gastroc inhibition. Is this any thought you've had?
No, not particularly that way. We There's not much association with these types of studies and the things that we do, because it's, as I said before, with the neurophysiology stuff, it's very hard to reproduce for people running. It's a very complex movement running. Um, so I don't know how much we could control during running to say that that's being caused by X or Y, Z muscle.
Mhm.
What we do see though is that even in healthy population, the lateral gastroc, when you're doing ramped contraction on the dynamometer and you're controlling your ramp up, the recruitment of the lateral gastroc is later than the medial gastroc and the soleus, and that's just how it is. We haven't looked at if that recruitment threshold, like the level of the recruitment of lateral gastroc would change in people with tendinopathy, or if the recruitment between the muscles would change. We haven't looked at that specifically. So that's definitely something, again, on the list of things to
Okay,
do.
yeah.
But yeah, it might be that the recruitment pattern changes. You have a further delayed of the lateral gastroc versus, or maybe a earlier activation of the lateral gastroc, or later activation of the soleus. I don't know. I know that physiologically in healthy people, it's soleus, medial gastroc, and later you have your lateral gastroc coming in or coming on board. But we don't know if that changes with tendinopathy.
Oh,
And
okay.
again, just to
Yeah.
be clear, because I know that it's very hard for people outside of neurophysiology to understand the different types of variables that we measure. When we say recruitment threshold is based on the firing rates of the motor unit when they start to fire during a controlled visual torque feedback control. So it's very controlled environment. It's not the same as seeing mechanical delay that we see with torque and surface CMG, and it's not the same as seeing just the delay on the EMG activity of the surface CMG activity on muscle contraction. That may represent something else, and it might not be very easy to interpret and to correlate clinically. So that's more complex to analyze than what I'm talking about. It's what I'm talking about is going back to that firing rate, the neurodrive, and more detailed, more unit analysis rather than raw EMG and this broad idea of and the many factors that could be influencing that EMG signal.
Okay, you
I don't
said
know if I
something.
was clear, Jake. That was a bit confusing, I
I
guess.
mean, yeah, it's a lot of big words
Yeah.
that I don't fully know, but you said something earlier on the lateral gastroc kind of like having this inhibition, but then it's almost like it like gets overexcited when the demand is very high. Did we saying something like that?
Yes. So there was a
Because
paper.
yeah, because I was gonna
Yeah.
say I felt like that was the same thing with ebony, with it's like the quads are inhibited, but then they also get like overexcited or something along those lines, and my terms are probably off. Um,
Yeah, there are
yeah.
different things that were measured. She measured the recruitment curve of the corticospinal excitability. So she found also increased corticospinal excitability, which is what you're talking about there,
Hmm.
increased excitation of the stimulus curve um, plot. What I was talking about was this paper from Contreras from in 24, I think it was. And they measured different levels of contraction. And they did, on top of the intensities that we did, they also did a 70% of maximal torque. So the way we do this, we get the participants to do a maximal contraction, right? An MVC, a maximum voluntary contraction. And then we work with percentages of that force. So if they did X amount of newtons, we're going to say, okay, what's 20% of that? And then we do a contraction with the top of the contraction being 20% or being 10% or being 70%. And at 70%, this paper found an increased firing rate or increased neurodrive of the lateral gastroc, which could be compensation for the earlier, the lack of um, contribution during submaximal contractions. Then it just comes all in, So, but it's, as I said, so it's different papers showing different things. It's hard to put it all together because there are different measures. What we can see, though, as I said, as a summary of those papers, is that uh, everywhere we look, the lateral gastroc is showing that there's something that is just not behaving as a control or someone without tendinopathy um, would behave. So the neurodrive or the activity or the contribution of force production is different somehow. And as I said, I think it's just something we need to explore further and and keep developing our thoughts and our knowledge around that. It was too early stages
Hmm.
on this. They're very early types of studies investigating this, but they're very exciting. At least I found it very exciting.
Okay, something Ebony had was that for the motor cortex was the metronome. Because you're talking about this getting this lateral gas. If this is a problem, training it with those um toe in position. Um, I'm kind of thinking, what else can we do? Is that something you think could be helping out? Is that something that has an effect on the nervous system to help work that? Yeah.
Yeah. So one of the things that is being used quite a lot for cortical excitability or cortical inhibition is the use of external visual audio feedback. So the metronome is one of them. It gets you to control your contraction rather than just doing randomly and becoming automatic. So you're putting thought and effort into it. You're controlling it. Another thing that has a good effect on reducing inhibition is eccentric contractions. Um, and you might even explain why Alfredson's had, good
Mm.
success with Achilles. But I think it's just part of that. Part of that as well is um, the muscle specific. As we talked about, if the lateral gastroc is the muscle with the deficit, the foot position in would be enough to increase that activation. And as we've seen from the research training studies, is enough to cause adaptation in that muscle with, if you do it chronically with over time. So there are strategies for that. And I think it's just including them. As I said, the endurance calf raise I use with metronome um, for pace, to control the speed that they're doing. So it's easier to reproduce and to compare the number of repetitions they've done today and that they're going to be able to do in 5 weeks. But also in terms of intracortical inhibition will be a good factor because they're stopping and thinking and controlling, and that it's engaging more of that voluntary control and the drive to the muscle. So they're good strategies.
I never heard about that with eccentrics. Why is it with eccentrics that it helps? Is it because the loads are heavier, or is it because what is it?
That's a very good question. That's a very good question.
Yeah.
I can't remember the top of my head. Um, the mechanism behind eccentrics. I think the load being heavy is one of them, but I can't really remember the top of my head
Mhm.
the mechanism behind eccentrics, but it's one of them.
Yeah. Okay. So I've done a podcast with Karin Silbernagel in Delaware, and then this was a long time ago, but I recently did one with Rodrigo Scatone, and he was telling me they're doing a lot of E-Stim on the quads to get more tendon strain, and they're going to start doing it with the calves. Is that something like if you put the E-Stim on the lateral gastroc and you do your calf training, is that a way to enhance this have effect on the nervous system? Would that have could that have an effect, or is that like I don't know too much about like E-Stim, but or what the effect it has on the nervous system and the brain. Yeah, what are your thoughts there?
Yeah, so we use that nerve stimulation or the neuromuscular stimulation with that arthrogenic muscle inhibition as to very classic post-op ACL, post-op knee surgery. We all use it, and there's definitely a good strategy that definitely increases the involuntary activation, so that doesn't work passively. It works in conjunction with exercise with resistance training. So you're doing your exercises as normal, and the nerve stim is just adding that extra layer. It's just increasing that drive, just making that muscle contract involuntarily. So imagine you're doing 40% of your maximum contraction, and the nerve stim is doing the extra, 50 or an extra 40 or something, depending on the intensity. So just engaging your muscle fibers more intensely. Um, so that's what the muscle stim would be doing. It would be giving that extra input or the extra peripheral component. And over time, with the feedback that we get from the muscle contracting, we stimulate the neurodrive as well. So that helps with that cortical inhibition by increasing that peripheral input that's not arriving at the muscle.
Mm, okay. Okay. Last one I got for you here. It's late for you over there. Early here for me. You were talking. I had a question on that, and you kind of cleared it up for me. So I want you to see if you can do that on the show here. This whole subtendon twist thing, and there was that paper on the foot out position having more. And you told me what it was because I kind of had it wrong, but the foot out position had more of like this sliding and gliding thing, maybe between the subtendons or inside the tendons, versus like the toe in position had more like, to me, like more of a stiffening up type thing. When we start talking about the subtendon twist or like the fascicle twist within the tendons, what's going on when the feet are out and the feet are in?
Yeah, I think that there was, as we talked about, there were different papers. One of the papers measures the strain of the tendon with the horizontal position, so the foot being in or being out. So the foot position out would increase the displacement of the lengthening of the lateral gastroc, the medial gastroc, sorry, and reduce the lateral gastroc. And the other way around with the foot in, it would increase the lengthening of the lateral gastroc and reduce the medial gastroc, which makes sense because increasing the lengthening, increasing the strain, it ties well together with the force capacity and the contribution force. The other one that we talked about was the interfascial sliding, and that's on the free tendon, is not on the subtendon. Is where the Achilles tendon becomes the free tendon, and it's the sliding of the deeper and the superficial layers that we talked about the tendon twist. And You have the deeper layers and the superficial layers, and we have the interfascical sliding. So the tendons are sliding and gliding when we move.
Mm,
So they're
okay.
different things.
Um, okay. Yeah, we got covered a lot of stuff here. I think it's funny at someone I posted on Instagram that I'm going to do a lateral gastroc tendon podcast with you, and they were commenting how niched down I am. You know, I'm going to do an hour podcast on the lateral gastroc. How crazy is that? Um, yeah, tell me what new. What are the new things you're working on?
Yeah, so as I said, I have this PhD student that I'm co-supervising on the same university that I did my PhD. So she's continuing in a way of saying, where I stopped. So she's looking at the different muscle contribution and activation during fatigue. So as we found a lot of the endurance deficits in the calf muscles, we stimulating fatigue and measuring the muscles throughout this process. So we're gonna have one study that we just almost finished, and we have another two studies that are gonna be looking at different things fatigue related and how the each muscle contribution changes with fatigue, and and see if we can explain some of the things that we saw in terms of with the participants rested, and now if that can be observed more clearly, if that exacerbates when they are, with the muscles are fatigued. I am also organizing. I have this survey that we talked about, and I have a few projects on the drawer that I'm starting next year. One of them is going to be with single leg calf raises, and we're trying to see how we can improve the protocol to make sure that it's going to be easier to test. And as I said, like I think that working in a way that becomes easier for patients is a good way to go, especially with telehealth and some patients not having access. Here in Australia, we have a lot of regional communities, and some of them away from the closest clinic. There's a lot of telehealth. There's a big start of telehealth after COVID and during COVID and after COVID, and I think that developing these tests will be helpful for that as well. So that's definitely on the list. But I think that as I've mentioned, I think one of the interesting things that I want to look at is the more explore more about that relationship of each muscle in runners with tendinopathy, and try and see if there are more the nuances that we don't know yet. And there are a lot of the questions that you brought up. There are a lot of very good questions that we're still trying to figure out a way of answering that and testing that. So that's definitely on the next steps, trying to answer all your questions, Jake.
I was gonna say earlier, I'll put that survey in the notes. I did it
Yeah.
myself the other day. It took me like 10 minutes.
Ah,
Um,
great.
yeah, so hopefully we get some more people to do that.
Yeah.
But yeah, man, tell everyone where to find you online.
Yeah. So my Instagram is Gabe Physio, and so is my Twitter. I'm a lecturer at Southern Cross University in Australia. So if you go Southern Cross Uni and put my name in, you get my email and my details there. So, if you're watching this and want to do a PhD with me, just get in touch.
All right, man. Thanks for coming on.
Yeah. Thanks, Jake.